So in this mini ECG nugget talk, I'd like to introduce a generalized approach to interpreting tachycardias. Now, the first rule about interpreting tachycardias is not to get tachycardic yourself. These ECGs that you see are simply a representation of someone whose heart rate is above 100 beats a minute, which is the definition of tachycardia. Often they look alarming. The patient may look unwell, they may not. And the critical thing to remember is that actually the most common form of tachycardia that you will see in primary care is sinus tachycardia, where the heart is beating in a completely normal rhythm, but at greater than 100 beats a minute. And as a consequence, the treatment or the management is really figuring out what the underlying cause of the tachycardia is. And often that's just the patient being anxious in your surgery, understandably, from being undressed, having a heart test that they worry about. And what I would say to you is, if you remember, there is a 10-step system to interpret the ECGs, where we start by the integration. We start by asking you to think about the indications, the demographics, and then looking at the rate as the first step. Now, the point I make is, if you find that the rate is 100 beats a minute, at that point you pause that 10-step system and move into this tachycardia interpretation algorithm, and I'll talk you through it. So on the slide, you will see that the first thing, well, as soon as you acknowledge that the heart rate is above 100, assuming the patient is well, hemodynamically stable, etc., you look at the QRS width on the ECG, and you ask yourself a simple question: is the QRS width narrow or is it broad? Now, if it's narrow, you go down and ask yourself, if it's narrow, is it regular or irregular? And if it's an irregular, narrow complex tachycardia, it's almost definitely going to be atrial fibrillation. If you have a regular, narrow complex tachycardia, you've got to ask yourself, can you see P waves before every QRS, or can you not see any P waves before every QRS? If you can see P waves before every QRS, this is sinus tachycardia. Happy days, you know exactly what you're dealing with. This is potentially just an anxious patient, or someone who's got an overactive thyroid or anemic. Those are the classic causes of sinus tachycardia. If you see someone with no P waves who has a narrow complex tachycardia, the differential here is one of a supraventricular tachycardia or atrial flutter, specifically if it's 150 beats a minute. That's what we call atrial flutter with 2-to-1 block. So if you see someone with a narrow complex tachycardia which is regular with no P waves, and the heart rate is bang on 150 beats a minute, the three leading causes of that particular scenario are: number one, atrial flutter with 2-to-1 block; number two, atrial flutter with 2-to-1 block; number three, atrial flutter with 2-to-1 block. So that's how confident I am that pattern will represent atrial flutter. Now, broad complex tachycardias are a different story. They're more concerning because typically they suggest that the tachyarrhythmia, the arrhythmia, comes from the ventricles. And again, it's the same thing. Is it regular or irregular? Now, if it's an irregular broad complex tachycardia, this may just be atrial fibrillation with a form of bundle branch block, left or right bundle branch block. It may be due to something called torsade de pointe, or it may be due to something called pre-excited atrial fibrillation, which is a consequence of someone who has a syndrome like Wolff-Parkinson-White, where you have an accessory pathway. Now, if you have a regular broad complex tachycardia in which you cannot see P waves, that is ventricular tachycardia, and that is a medical emergency, regardless of whether your patient is conscious, unconscious, or feeling unwell or feeling well. That patient needs to be blue lighted into a secondary care setting to have that treated emergently, because ventricular tachycardia will not be tolerated for very long, and a patient will eventually be compromised and in all likelihood have a cardiac arrest. Conversely, if you have a broad, complex, regular tachycardia in which you can see a P wave before every QRS, this is sinus tachycardia with some form of bundle branch block, be it left or right bundle branch block. So that's your algorithm for assessing someone with a tachyarrhythmia. You do it early on once you've established that the rate is above 100 beats a minute. The commonest cause in your practice will be a sinus tachycardia.